to how long nearby, but not in my phone, so I met the visit your city today. I'm coming from the city of Perugia, but maybe work in Firenze. Be that some of you know these two cities name. Or the city of Perugia. The landmark of the city is the fountain over there, which is practically 800 years old, more or less. So the city was created by Etruscan 3,000 years ago, and now is mainly medieval. The University of Perugia is one of the oldest in Italy. It's the third oldest, and is around 750 years old. So I have not particular confidence to speak today. Yeah, it's the battery. The topic I'm going to address today, I try to convince you that we have to make at least some new vision in maternal fetal medicine. One of the big problems we have in obstetrics still is that we address mainly all the disease by clinical presentation. If you think, when I talk about preeclampsia, I speak about two signs. One is hypertension, the other is proteinuria, but I don't define what is the etiology of the problem, and still we don't know the etiology of the problem. If we go to our colleagues in the internal medicine department or in infectious disease department, I cannot now make a diagnosis of cough if I have a problem in my chest, because they will define that the cough is coming from a pneumonitis coming from cytomegalovirus. So the definition is very clear. But we don't have this kind of definition still in our obstetric terminology. And we are old in this, we have to change. The diagnosis in many of diseases in obstetric only refer to clinical manifestation. However, we know that these clinical manifestations are not part of a specific disease, like in the infectious disease due to a microorganism, but it is a series of etiologies we define more as syndrome. And we recently, 15, 20 years ago, we tried to define this disease as obstetrical syndromes. And this is one of the editorial which I published in the Black Journal already in 2009. Why the obstetrical syndrome? Because if you think, any of the disease which is manifested in pregnancy has multiple etiologies. Just think to preeclampsia, long preclinical stage. When the hypertension manifests, the disease is already in since a few weeks. Frequent neonatal involvement, for instance, preeclampsia, we may have intrauterine growth restriction. And is influenced, this disease, by gene-environment interaction. We know that according to nutrition, to gene predisposition, so on, preeclampsia is more frequent. And finally, the clinical manifestation is adaptive in nature. In fact, the hypertension in the mother is an answer to the decreased vascularization and the flow from the placenta to the uterus and to the fetus. So it's a reaction more than a specific problem. So we have to try to change our mind in this. And there is nowadays accumulating evidence that also preterm birth, preterm rupture membranes, small for gestational age, large stillbirth, recurrent miscarriage, they are not a single condition, but they are part of syndromes which account for more than one etiology. I try to convince you in this way, in showing what is probably the underlying etiology of all these problems. The first is implantation. Implantation, in order to be successful, at least in humans, needs a change of tolerance, immune tolerance, from the mother, from the host, to accept an incompatible embryo fetus. Because we are a sort of semi-allograft, because our cells, because a mix of the paternal and maternal cell are not the same as the mother. So when the cell arrive in the uterus and they want to implant, they should be recognized as not enemies or virus or bacteria and contrasted, but they should be accepted. And this is a mechanism which is mainly due to the progesterone action on the lymphocytes, because progesterone produces in the lymphocyte a so-called progesterone-induced blocking factor, which has different actions. The first is to try to change the compartment of lymphocyte toward Th2, because Th1 are those which are activating macrophage, and the action against any cell which are in our body. Secondly, we have to increase the natural killer cell activity, which is present in the uterus, by the way, in the endometrium and also in the decidual. And third, to block antibodies production against, for instance, the trophoblast or the fetus. All these actions are pertaining to this compound, which is produced by progesterone. If we have enough progesterone-induced blocking factor at the cellular level, then we have a fetal protection, and the pregnancy can go on. While if I have not enough, I have a cytotoxic inflammatory abortogenic reaction, and I have most of the time rejection of pregnancy. So this is the first step. Implantation requires immunotolerance. Immunotolerance requires progesterone. Second is formation of placental bed. When we're talking about placenta at 8 weeks, it's not really placenta. Placenta takes 3-4 months to be developed. It's a very long procedure. And the development of this new blood vessel, which communicate between the mother and the fetus, is under the balance of angiogenic and antigiogenic factors. Very subtle balance. And the main hormone which are controlling uterine blood flow and allowing the invasion of trophoblast on the spinal arteries in order to create communication are progesterone and estrogens. And progesterone mainly because it's the balance between the two that allow trophoblast to invade the spiral arteries and to destroy the muscle of the spiral artery in order to be not reactive. And of course, VEGF and other angiogenic factors are produced in the vessel which form the villi. All these trophoblast migration, trophoblast association remodeling, and reendothelialization are mechanisms which are very, very fine, very subtle, which need a balance between hormones, between estrogen and progesterone particularly. And you know that if we have invasion that is not enough, the trophoblast invasion is too deep or too low, then we have different responses. Because our vessels answer to any factor which creates vasoconstriction, vasodilatation, and this hamper the circulation of the placenta. So look, for instance, when the trophoblast invade the spiral artery, destroy the muscular glucose. You see, there is a destroyment, and this is normal in pregnancy. But if you see still the muscular glucose like here, this is not normal, and this is the prerequisite for preeclampsia. So what is happening is that if I have a normal pregnancy, the spiral artery invaded until the membrane between the decidual and the myometrium, this is the correct. If it's going too low, Then I have a series of alterations with a fluctuation of oxygen, ischemia reperfusion type, and what we call oxidative stress increase. Now, this oxidative stress is probably the reason why we have a lot of phenomena and phenotype in pregnancy, because when I have this oxidative stress, normally in any pregnancy, there is enough antioxidant defenses in the mother to make a resolution of the oxidative stress to normal placental function. But if I have some underlying disease or metabolic disorder or mitochondrial dysfunction, or the mother is affected by lifestyle derangements like drugs, smoking, alcohol, epigenetics, environment, so on, what is happening is that I have degeneration of this. So the oxidative stress is producing damage, and the damage is producing, what we call miscarriage, or later on, insufficiency of the placenta, and later on, growth restriction, and so on. So there are different phenotypes, and this is quite clear because we measure, for instance, the total antioxidant capacity in the blood of mothers with gestational diabetes preterm labor. You see that is much less. And the prooxidant capacity, so oxidative stress is very high. So the pathology of placental bed, which is consequent to implantation, defective implantation, is accounting for all these problems. And all these problems are different manifestations clinically according to the let's say the contact with the maternal body. So it's the maternal background which may justify preeclampsia, or may justify miscarriage, or may justify preterm labor according to the risk factors which are in the mother. So all the placenta bed formations, spiral artery remodeling, create a different phenotype according to interaction with the maternal body. But the underlying system is very similar, very similar. Implantation defect and the placental bed formation defect with an increased oxidative stress. Saying that, nowadays, obstetrical syndrome may be, let's say, more comprehensive in trying to understand what are the problems and to try to make a prevention. However, if we don't consider this underlying cause, the diagnosis will remain elusive and the result unpredictable and the cost enormous. Just think to preterm birth, for instance. So we have to change a little bit our paradigm. Let me now mention a moment the progesterone role, because I mentioned at the beginning and I told that progesterone is key hormone either for implantation, either for placenta bed formation. Now you can download free this volume of the Clinical Obstetric Gynecology, British Medical Journal, also in Vietnamese language translated. You can download free, and is a volume which I edited, in which there is all the action of progesterone in obstetric gynecology. If we look at the pharmacodynamic profile of progesterone, you see that nowadays what we know about this hormone is that it has a lot of effect on maternal immune response, on the secretory exchange of endometrium, on suppression of fetal inflammatory response, reduce uterine contractility, is a very potent antiprostaglandin drug. The molecule of progesterone is similar to a steroid, so it's an anti-inflammatory substance, mainly progesterone. All these are in keeping what I'm saying. Progesterone prepares endometrium for implantation. I mentioned before already what are the actions. But there is an action which is most important, also thinking to assisted reproductive technology, is the fact that progesterone is the only hormone which inhibits uterine contraction in when the embryo arrives in the uterus to implant. We need to have a quiescence of the uterus in order for the embryo to implant properly. And if you look, for instance, these are studies from IVF. If I have enough progesterone, the chance to implant normally are much higher than if I have low progesterone and more contraction. And this contraction can be seen by ultrasound. So when I put an embryo after an IVF, I have to have an amount of progesterone which control the uterine contraction. Otherwise, the contraction will impair implantation. And this is obtained only with the natural progesterone, beside all the other actions. Maintains pregnancy. How is important that the progesterone then be produced by corpus luteum? Because corpus luteum probably not only produce progesterone, which is so important, but also other substances which are useful for the normal placental formation. For instance, the inhibins, the relaxins, and so on. And if we don't have a normal corpus luteum, and you know that you expert in IVF, you know that now with the fashion of transferring freeze the embryo, you don't need a corpus luteum because you prepare the endometrium and you have already the embryo to transport to put in the endometrium. You have an increased risk of preeclampsia or placental anomalies because, of course, you don't have a properly functioning corpus luteum. Now, progesterone is a very interesting substance. Natural progesterone, particularly the one that is micronized, because before micronization, progesterone was available only by intramuscular route, by vehicle which is oily. But now with the micronization, it is absorbed by any mucosa. So can be absorbed by mucosa of the gastrointestinal tract, but remember that what is important is not only progesterone, but the metabolites of progesterone, which are produced in the body. So the most important metabolites for oral route are also some metabolites like allopregnanolone, which have an hypnotic effect, a sedative effect. So if you want, for instance, to treat premenstrual syndrome, which is in a period in which a woman has a lot of problems, neurological or psychological problems, the best way to treat is with oral progesterone. If I need to treat, for instance, mastodynia, I probably need only progesterone by transdermal route because it's available for, a very short without tissue, but no systemic effect. If I need more general progesterone, there are intramuscular subcutaneous routes. However, we should know that the concentration of progesterone then in the blood are supraphysiological, and they are probably too much. You will see in a moment. And finally, the route is vaginal or rectal, if you want, because that absorption is only at the level of the genital tract, very rapidly, in 3-4 hours, all the receptors are kept by the progesterone, and there is no systemic effect. And also, there are no hepatic passages, so no production of allopregnanolone, so there is no effect on the GABA system if you give by vaginal route. So vaginal route is the preferred one. You know that a recent evaluation by the European Society of Human Reproduction has reported that 80% of IVF centers in the world use vaginal natural progesterone, 80% of all the IVF centers in the world. So I believe that also your center use the same. And look at this. This is very important to understand. You know that when we establish that a patient has ovulated and there is a good concentration of progesterone, usually there is a magic number of concentration in the blood. And this magic number is over 10 nanogram per milliliter. Now, look at this. To obtain over 10 nanogram per milliliter, as our IVF experts know, is enough to give 600 milligrams per day of vaginal progesterone. So we have very high concentration in the genital tract and around 10 stable in the plasma. If I go more, if I give intramuscular, you see that I reach 5 times the concentration. And sometimes we don't know how useful they are. Okay, so the best is to give a concentration which mimic the physiology of the human. Now let me address one very important obstetrical syndrome, and you will be maybe puzzled by the fact that I say that preterm birth and miscarriage are one single obstetrical syndrome. But this is the reality. The difference between calling miscarriage or calling preterm birth is the capability we give to the fetus to survive. But there is no difference. The mechanisms are the same, and the risk factors are the same. So the only difference is the timing of pregnancy. Because before 22 weeks, we think that the fetus does survive, and we call miscarriage. If the fetus survives, we call birth, but it's preterm. Now, let me address the risk factor, and tell me if there is any risk factor which is not pertaining to both. Before pregnancy, genetics, heritability, ethnicity, black population, age of a woman, teenager or over 40. They may have miscarriage, they may have preterm birth. Reproductive system disease, polycystic ovary syndrome, is linked to abortion, is linked to preterm birth. Endometriosis is linked to abortion, is linked to preterm birth. Environmental factor, epigenetics, nutrition, and the previous preterm delivery is a risk factor for preterm delivery, but also for abortion. And previous abortion is a risk factor for abortion, but also for preterm delivery. You see that they are the same. The difference is the timing and the reaction of the mother. Then, during pregnancy, the same factor: stress, cervical insufficiency, uterine overdistension, uteroplacental ischemia, inflammation, infection. Tell me, when we have twins, who of you knows if the lady will make a miscarriage or make a preterm birth? Nobody. Nobody at the beginning of pregnancy. There is the chance is the same. If the mother is reacting well, she can arrive to 30 weeks. If she's not reacting well, she delivers 20, an abortion. So you see that the things are very similar, and the mechanisms are the same. There is a major activation, contraction, then there is a cervical opening, then there is a rupture membranes. These are the mechanisms, either in abortion, either in preterm birth. All these factors can be some way managed or prevented, except one, which I mention now. And this factor is to have a male fetus compared to the female. You know that if the pregnancy has a male, there are twice as more the chance to have an abortion or preterm birth compared to female. And this is something that is in any statistics anywhere. Why? Because probably nature protects more the female than male. To continue our human species, we need a female. We need not too many males. Okay, so the stronger sex in pregnancy, at least, is to be a woman, not to be a man. And in fact, the molecular aspect of placenta are quite different between male and female. Placenta in male is less protective. For instance, infection. If we have an infection in the mother, the infection passes more easily the placenta of a male and not of a female. And this is something important because nowadays we have to start considering that the placenta is not the same, it's not a neutral, but as a sex also the placenta. So if we have a male, it's a male placenta. If we have a female, it's a female placenta with many differences. And these may account for some of the differences in the result. Now let me address the importance of the karyotype, particularly for the abortion compared to preterm birth. We know that around 50% of what we call miscarriage are due to embryo-fetal anomalies, okay? In this case, we cannot do anything. We cannot do too much. Nature is eliminating the pregnancy in any case, whatever we do. However, when we think about the number of miscarriages with abnormal fetal karyotype, the role of abnormality is less important, more abortion I have. And there is more importance of the mother risk factors. Okay? So if I have an abortion, then you see that the number of risk which increase, which is practically logarithmic, one more abortion increase the risk of abortion, the 50% of fetal abnormality remain the same. What is increasing is the risk factor of the mother. That's why until 10 years ago it was impossible to get the data meaningful to establish a powerful, at least trial in which demonstrate if there is any tool which can help prevent, manage miscarriage, because all the data would be addressing very few population patients. I remember that the case report which had been done before 2015 were 100 cases versus 100 cases, 200 cases versus 200 cases. Then a big group of